Îmi face plăcere să am oportunitatea să vă prezint următorul invitat care va contribui la această zi. Este vorba de profesorul Xenofon Baraliakos, care lucrează la Centrul de Reumatologie din Herne și care lucrează de asemenea la Universitatea Renania de Nord-Vestfalia, localizată la Bochum. Cu certitudine, l-ați mai ascultat pe profesorul Baraliakos și cu certitudine știți că obiectul său principal de preocupare în domeniul medical este contribuția pe care rezonanța magnetică o aduce la cunoașterea mai bună a domeniului spondiloartropatiilor. Ca atare, acesta este și subiectul prezentării de astăzi. Xenofon?
Thank you very much, Catalin. I was not able to understand everything, but some of the words I could understand. And it's a pleasure for me to speak after Laura and also be with you on the web. Unfortunately, I cannot be there in person, but I will try to give you a little bit of a flavor on the topic that we chose together, Catalin, about how to use imaging or how to image spondyloarthritis in daily practice. So this is going to be, I would say, as practical as possible. Of course, using data, using images, but I will try to give you my opinion or the most current opinion of how to really apply imaging and really go from classification to diagnosis and back. And I would like to start by reminding you what the current status of the disease is that we call axial spondyloarthritis. And this is that we really try to stop using the terms non-radiographic and radiographic. We call it axial spondyloarthritis in daily practice, independent on whether or not the patient has or does not have radiographic findings of either sacroiliac joint damage or the spine, this means in desmophytes. You will see that in my presentation sometimes I will be distinguishing it because the data come from the studies that have classified the patient. Nevertheless, for daily practice, we use imaging to diagnose patients, and this, what you see here, is the classification. Now, one important thing to keep in mind is also that non-radiographic and radiographic spondyloarthritis are not always referring to different stages of the disease. I hope you can see my laser pointer here. If not, please let me know, otherwise I continue explaining what I'm pointing out. And you see here the same patient. On the left side, the STIR sequence, on the right side, the T1 sequence, and this patient had obviously symptoms that led him to us. And we did the MRI, we found a severe sacroiliitis on the right sacroiliac joint, a little bit less severe on the left sacroiliac joint. The X-ray was normal, at least nothing that we could report as being strongly positive for ankylosing spondylitis or radiographic SPA. So it would be a non-radiographic axial spondyloarthritis, but you see here this patient had severe erosions on the one side, and of course many on bilateral and large in extent fatty lesions or fat metaplasia, which brings me to the point to say that this is not an early disease anymore, even if the X-ray was non-radiographic, as we would call it. This is the late stage of the disease. The X-ray is just not able to catch or to capture all these lesions. So it is an issue of sensitivity and specificity of X-rays and MRIs. And that's why, please, for daily practice, when you use imaging, use it only for diagnosis and not for classification. Again, these are classification criteria. We may use them after diagnosis. So we have the diagnosis and then we say, does this patient fit or does not fit into a study protocol? So does he or she fulfill or not fulfill the criteria? But otherwise, that's it. One reason to believe that imaging is important, or MRI especially is important to capture inflammation better, or obviously that's the only way to do it, in contrast to X-rays, is older data that I pulled out from my older presentations here, where we, at the very beginning, it's more than 10 years ago, you see the reference, in the very beginning when we tried to establish the ASAS classification criteria, we tried, among other things, to compare the performance of the SSG criteria and the AMOR criteria that you certainly all have heard of, with or without MRI. And you see here the sensitivity and specificity in the so-called ASAS cohort. This is the cohort that was used for the classification criteria. And we found out that adding MRI to this existing criteria adds a lot on sensitivity and does not lose or does not change the specificity of them, which means that you capture more patients and you capture them securely. This means you do not make a wrong diagnosis. And the other thing is that when we compare this then with a whole set of the new criteria, the ASAS criteria as they were published in 2009, we found that the sensitivity remained the same, but we added on specificity. This means this is indeed, I'm not talking about the criteria themselves now, I'm just talking about the MRI value within the whole context of spondyloarthritis as it is defined nowadays by this criteria. That is why X-rays are okay, but MRI seems to indeed increase our sensitivity overall, and that's why imaging is important. That's why I'm speaking with you today. By the way, you see the same sensitivity for the ACR, for the ACR-EULA criteria for RA, but since they are missing imaging, the specificity is extremely low as compared to the spondyloarthritis criteria that we have. So imaging is important, obviously. Now, asking ourselves why or how many patients will we see in daily practice by using imaging, that might have, you may have seen this slide before. I do still like it very much because it shows more or less what I also see in our daily practice. These are data from the French cohort where they try to ask exactly that question: how many patients do I in my daily practice capture by using imaging or by using clinical criteria? And you see here 3 out of 5 patients were chosen to have spondyloarthritis by the rheumatologists who were seeing them, and in 2 out of 5, this means 50% less, were chosen by the clinical arm only without having imaging because it was not able to be done, because the patients did not want to go on the MRI or whatever. And when they asked which kind of imaging did I use, or when they asked themselves, what did I use for diagnosing my patient, then they saw that indeed the X-ray and the MRI were actually in combination used most frequently, 50%, but MRI throughout was used in more than 80% of the patients, or was taken into account as positive, which means that X-rays are still very important. And I do not say that we do not use X-rays in our hospital, but obviously we also need to use or be more sensitive and specific. And you saw that before, and this is the world that we are living in right now. The usual suspects of MRI sequences, I will talk about sequences later, are the ones that are also being used in a broader context of a cohort and also in other countries. Now, a newest study that was published very recently also tried to ask which kind of X-ray technique should I use. Should I use the lumbar spine and then check for the sacroiliac joints, or should I use the pelvic X-ray and check for the sacroiliac joints? And you know that this might be a kind of a hassle, because sometimes you do this X-ray of the pelvis in the standing position. This might be done in the lying position or differently. I just want to say that out of the study, you see here how many patients were captured by the lumbar AP and the pelvic radiograph, either at baseline or 2 years later. This is this graph at the bottom. There is no big difference. So if the patient has lumbar spine and buttock pain, then I would prefer to do one X-ray to reduce radiation and include the sacroiliac joints in here. If the patient, especially the younger ones, have buttock pain and hip pain, which is also a bad predictor for the disease, then I would rather prefer to have a pelvic X-ray and evaluate the X-rays in the sacroiliac joints in there. Of course, you have to pay attention in image A, in the lumbar spine and the sacroiliac joint. Sometimes you see, we do not see the entire sacroiliac joint because of the of the X-ray and how it's being done. We have to advise the radiology technicians to a little bit broaden the focus. But that's something that we do. I would like to point out. The results are not different either, independent of which X-ray technique or focus you're using. And then when people, although I don't say we should do that, but nevertheless it might be done, and that's daily practice. when we can say that we're using the classification criteria to be sure for our suspected diagnosis. What was done in this study was to take the patients who had fulfilled the classification criteria in the beginning and checked 5 years later when the clinician made a diagnosis. So really 5 years later is a long time to really be sure that you had a diagnosis or not. They did find out that the positive predictive value of the classification in the most of the times also confirmed the diagnosis, and the negative predictive value was not bad either. This means what was positive on the ASIS classification criteria was also positive for diagnosis, and what was negative actually was 50% positive for diagnosis later. What I want to say is that we should not be using classification criteria for diagnosis, but if a patient you have diagnosed also fulfill the classification criteria, then you're pretty sure that this patient has spondyloarthritis. This includes imaging, but of course also includes clinical criteria. So overall, they may be interchangeable, but nevertheless the physician, the rheumatologist is a specialist, and even if a classification criteria are not fulfilled, we can still use imaging, for example, for diagnosis. And by that, for example, in order not to make it too complicated, I remind you that, for example, the classification criteria use sacroiliitis as the imaging finding for spondyloarthritis. However, we may be able to make a diagnosis by using the spine MRI, and I will show how to do it later on. Now, one thing that is also, of course, important is what the patient reports and what the patient is caring about. And what the patients are caring about most is, of course, how much pain they have and how much they can move. And again, I bring it back to the imaging. What does imaging tell us into this for this topic? And you see here we have analyzed the mobility restriction by the BAS-ME with the X-ray correlations and the MRI correlations. So this is structural changes, this is inflammation. The p-values you see here are the correlations, whether or not the correlation was significant between X-ray and MRI to mobility restriction. And we found out that in those patients who were diagnosed early, their mobility restriction was significantly associated with inflammation. In those patients who were diagnosed and treated later, so they found their way to the rheumatologist later and they were diagnosed later, there unfortunately the mobility restriction was correlating to the X-ray score and not to the MRI anymore, which very simply means that we do have in the beginning inflammation that is the problem. We can treat early and we can fight against inflammation. If we leave patients either undiagnosed or the referral strategies do not work, or we have long waiting lists, and of course this will not be 3 years, but nevertheless we have a delay, excuse me, their chronic changes will come in, then we can fight against the remaining inflammation, but the chronic changes cannot be changed anymore. This is why early diagnosis and early treatment is important, and this is why MRI is important, to see patients early and to start treatment early. Now, the other question that I believe something that some people may ask also is, okay, for classification and for diagnosis or for daily practice, what kind of sequences do I need? Do I always need gadolinium, or can I use the STIR sequences? You see here the response to this question. We have a similar depiction of osteitis, which means that the STIR sequence is good enough or as good as the gadolinium sequence to capture sacroiliitis. You may even see a little bit of synovitis here on the right side, and you may see better depiction of capsulitis with gadolinium, but this is not typical for spondyloarthritis. That's why I stay on to the opinion that STIR sequences are absolutely okay. You can use them in daily practice. You do not need gadolinium, you don't need the cost of gadolinium, the time for gadolinium, and also the adverse events. And we've shown the same thing also many years ago for the spine. So the situation does not change in the spine as compared to the sacroiliac joints. Osteitis and maybe also some soft tissue edema around the facet joints is being similarly well captured by STIR. Now, if we see this edema, if we see this bone marrow edema and inflammation, what does that mean? It means, first of all, that of course we can use it for diagnosis and later for classification, but it also means that we have a bad prognostic factor the more the signal extends and the more intense the signal is. You see, in this study, they found that the more the extent of the signal was, and the more the intensity of the signal was, the higher the likelihood ratio for developing structural changes about 8 years later, as compared to the areas where they had less extent and less signal. And there, the sacroiliac joints also showed structural changes, but the likelihood ratio for developing them was much lower. It was 20 times lower as compared to this one after 8 years in the long run. So this is also a prognostic sign which makes us also maybe think about escalation of treatment even earlier. And the same is true for the spine. We have here data after 2 years, not after 8 years. And the studies that I show you here all showed the same result. 3 times higher risk, significantly increased in those areas where we have inflammation as compared to those where we do not have inflammation, or we have less inflammation to develop syndesmophytes. And we also have found after a couple of years that it's not only the inflammation that leads to the new bone formation, it is more than that. It is the, sorry that this has been misplaced a little bit, it is the fatty lesions, what comes after inflammation, that is significantly associated with new bone formation. So overall, the long-standing inflammation, that brings me to the earlier study by Pedro Machado, the long-standing inflammation will then turn into fat and then turn into new bone. That's why imaging is important to diagnose, but also show the prediction of the lesions later on. And that's something we're also using in daily practice anyway. Now, when we talk about imaging, we also talk about, and the prediction, one question can also be, okay, if that's so important, how frequently should I use imaging, especially MRI now, because in the X-ray you see, obviously, the syndesmophytes, that's pretty late. How often should I use imaging? How often should I use MRIs? And in this picture, you see older images that I obtained from one patient of ours in the outpatient clinic, where he came in with this spinal MRI, and 3 months later with with NSAID treatment only, you see, for example, that lesion has improved by itself without giving any biologic. Excuse me, this lesion has worsened. So there is a high fluctuation rate, and that's something we need to take into account. And we try to do this in a study where we took patients who really had high levels of pain. They would have been eligible for a study. They were taken into the placebo-controlled arm of the study, and they were clinically positive, but their MRI was negative, or the CRP was negative, or both were negative. And after 3 months, only with NSAIDs in the placebo arm, we tried to check who of those, or how many of the MRI negatives turned out to be MRI positive, how many CRP negatives turned out to be CRP positive, and those who were both negative, how many of them were turned out to be positive for the one and the other. And you see here the number that is important for us for today's talk, 30%. So every third patient after 3 months turned out to have inflammation, which was for sure SPA related, which is a pretty high number to my opinion. So it seems to be that indeed we do have a high fluctuation of inflammation. And for the use of MRIs, I would recommend, if you are not sure, because the imaging may be negative, but you think that the patient has spondyloarthritis, either to treat already early, or if you don't want to do so, or you don't have the resources, to at least repeat an MRI of the area that is of utmost importance in the body and check what happens there. Now, when we talk about MRIs in back pain and inflammatory back pain, I like to quote this study that showed in the Desir cohort of all patients with back pain, or especially in those who fulfill the ASES classification criteria, that exactly there where I have the pain, I will also have a significant association with where the inflammation is. This means if the patient complains, let's start in the bottom. If the patient complains about buttock pain, then most probably the sacroiliac joints will have sacroiliac joint inflammation. If the patient complains about lumbar pain, then most probably, and that's significantly correlating with the data of MRI, the lumbar MRI is important. If the patient has thoracic pain, then don't do the sacroiliac joint MRI, do the thoracic MRI, because obviously this will be more important to correlate with the pain and show you what the patient has. And that's how I would apply my MRI resources, and that's also how I would do the diagnosis. This means you can do a diagnosis of spondyloarthritis by a thoracic MRI, because the patient has the symptoms there and you see the inflammation there, and this will correlate pretty much with the symptoms. You don't, for diagnosis, for classification you need the sacroiliac joints, that's true. But for diagnosis, again, you may do it also with a spinal MRI, that's the same, and you are the specialist to decide what kind of MRI should be done. And this study that I'm quoting here is, I think, also pretty interesting. The question was, do I need the spinal MRI in addition to the sacroiliac joints MRI? As compared to what I told you before, you see the numbers here. Both for the non-radiographic and the radiographic, the combination of sacroiliac joints and spine does not really add much information. Here for the non-radiographic maybe a little bit, so you increase the positives on the MRI from 34% to 50%. That's okay, it is a little bit of addition, but those who have ankylosing spondylitis already, which we did not know at that time, they will not change much. So the spinal MRI adds just a little bit only to the sacroiliac joint MRI, and that's why you have to decide where the pain is. If you look at the patients who have a negative MRI in the sacroiliac joints and ask how many of them will have positive MRI in the spine later, here you see the opposite first. So MRI of the sacroiliac joints is positive, 60% are also positive in the spine. MRI of the sacroiliac joints is negative, 50% are positive for the spine. Which, in order to summarize, because this was also a lot of numbers in a short time, if you have a patient who you want to diagnose and you don't know how to use your imaging, either do a sacroiliac joint MRI first and check what happens. If it is negative, repeat it 3 months later, or do the sacroiliac joint MRI first. If it is negative, do the spinal MRI immediately. 50% will be most probably positive because they have pain elsewhere, and that's something to remember. So, and that's how I would use, again, I would go on with in the daily practice. Or if the patient has no buttock pain, just do the spinal MRI immediately. That's independent of the symptom duration. This is a little bit of an information aside. So how would I suggest to do the MRIs overall? We know that we would be using the STIR sequences. I mentioned that in the beginning. However, there might be situations where, like ours, where patients do not come to the rheumatologist first, but go to the orthopedic surgeon. And the orthopedics do mainly the T1 and the T2 sequences first, because that's better for them to show the anatomical structures. We have an arrangement with our orthopedic department, and I think that's something you can also do, also with the orthopedic guys you're working with, or with a radiologist, where if a patient comes in and gets the normal MRI sequences, T1 and T2, for lower back pain, and nobody thinks about spondyloarthritis, then we also get, and the patient is, by the way, below 45 years, then we also do a very fast STIR coronal, not semi-coronal, but coronal sequencing that is about 2 to 3 minutes, not longer. And this is a slice thickness beyond 3 millimeters, which is the standard, up to 6 millimeters, 4.5 millimeters to 6 millimeters, so really thick slices. But you see what you can find in such a patient. This is the same patient. There was nothing in the lumbar spine in T1 and T2. However, on STIR, we could screen and find a left sacroiliac joint inflammation. You see that on my pointer here in the sacroiliac joint. And this patient was then brought or referred to the rheumatology department like ours to get the diagnosis of spondyloarthritis. Excuse me. This means, again, you can also apply a protocol like this where you screen for back pain and for sacroiliac joint inflammation in those patients who have chronic, this means more than 3 months, chronic back pain, who also are below 45 years. That's not many of them, but still you can screen pretty nicely to get the positives out of the negatives. Now, if we talk about where exactly to apply the spinal MRI overall, you remember I mentioned that we can do the diagnosis by spinal MRIs as well. I'm referring to this study that we were able to publish many years ago, where we found that if you do an MRI of the entire spine, these are the segments: cervical, thoracic, lumbar, then you see that the inflammation is most frequently seen in the lower part of the thoracic spine. And that's something important, because if the patients complain about low back pain, we need to very exactly localize where this back pain is, and do not, for example, do on the lumbar spine, but advise the radiologist to also scan the lower part of the thoracic spine. And this is important because also in the X-ray changes that we see, that we obtain, we may, I go back, we may not be able, or we may not have been able so far to check the thoracic spine so nicely. That's why, because of the overimposed lung tissue, we have not been analyzing the thoracic spine so much. Nowadays, we can include the lower part of the thoracic spine in the X-rays, or by applying digital imaging, which I suppose you may also have in some of the institutions. Then also the thoracic spine may be processed and be seen pretty nicely, and that's a very important and very sensitive area, even in the X-rays, to see new bone formation, even if in the lumbar and thoracic spine you see nothing. And we've obtained this information also by low-dose CTs. I'm not saying that we are doing low-dose CTs in daily practice nowadays, but you see, this is the beginning, this is 2 years later. The more green it gets, the more syndesmophytes the patients had, and these are two different readers here. And you see that both in the beginning, but also 2 years later, the patients had syndesmophytes in the lower part of the thoracic spine, and they progressed also in the lower part of the thoracic spine by low-dose CT. This means this part is also important, and I would advise you to do that or include it in the CTs, in the X-ray, sorry. Now, one last part of the presentation is how exactly to differentiate positive MRIs from false positive MRIs. And we've published that, and also others have done this kind of work, published and say that, well, where do you see the inflammation actually in spondyloarthritis, and where do you see the bone marrow edema in the bone stress areas of patients? And we've seen that indeed spondyloarthritis have inflammation more in the middle part. You see that also in the axial sequences here in the middle part of the joint, whereas bone stress, false positive inflammation, is seen more in the lower part of the sacroiliac joints. I'm talking about means now, not everything is black and white, obviously, and more in the anterior part. That's the that's the gut, and that's the back. So more in the anterior and in the lower part of the sacroiliac joints, and that's an important information when you interpret MRIs that may not be positive, or not for you, the patient may not be positive in clinics, but the radiologist says, well, there is sacroiliitis or there is inflammation. I just had a patient yesterday on that. So the more spread out the inflammation is, the bone marrow edema is, and the more in the middle of the sacroiliac joint it is, the much more related to spondyloarthritis this will be. And if it's in the front, in the lower part, in the front, in the ventral part, then we actually talk about bone stress. I do not know now, Kathleen, please advise me, do I have a couple of minutes left? Can someone tell me if how much time I still have to speak? I cannot hear you, so I will continue, and please interrupt me when the time is over. What we have done in another study where we tried...
Xenophon, you can hear me?
Yeah.
Okay, so take your time, no hurry. We can stay with you for 20 minutes more, no problem.
Okay, no, that's too long. I will not complicate things that much. I just need, I think, 5 to 7 minutes. Okay.
Okay, that's perfect.
Okay, so what we have done was to try to find out, I go back one slide, what kind of other lesions we may use in daily practice to diagnose now, to really diagnose patients by MRI, and not only rely on edema only, because as you see here, it might also be false positive. And we asked the radiologists who were blinded, what do you think, is this MRI, is it a positive MRI for spondyloarthritis or no? And we also had our diagnosis. where we were sure this patient has or does not have spondyloarthritis. The radiologist again was blinded. We had 300 patients with or without spondyloarthritis, and you see the results here. In those where the radiologist said there's a critical reason for saying that this is disease or this is not spondyloarthritis, in those patients where we agreed, then it was not the bone marrow edema alone that the radiologist said it's critical for me to say it's SPA, but it was mostly the combination of edema and chronic lesions like erosions and fat. So this is the majority of where we agreed that this is spondyloarthritis. And the majority where we also agreed that this is not spondyloarthritis, or actually all of them, had only bone marrow edema and there was no chronic lesions. This brings me very shortly to the summary that chronic lesions give the radiologist the security that this might be spondyloarthritis. And if it's only bone marrow edema, which is like this here, and there is no structural lesions, which is like the situation here, then actually, at least in this study, none of those patients got the diagnosis by the radiologist of spondyloarthritis, or at least they were of the same opinion of us. We also had some false positives where the radiologist says, yes, this is spondyloarthritis, the rheumatologist said this is no. And you see this was all chronic, where they maybe have crossed the line a bit, I would say, but there was no bone marrow edema at all here. So the combination of chronic and acute lesions is very important for the radiologist in daily practice. And that's something that I would also transmit as a message to your radiologist. At some point, we can also discuss this together with them if time allows in the future, because that's something I believe very important. And that, I know it's a very complicated slide, but I will show you the message of this slide. We try to check at the same study what sensitivity, specificity, likelihood ratio, the odds ratio, and the predictive and negative, positive and negative predictive value looks like. And you see the numbers that are red. These are the most important ones. They are always in the middle. And in the middle, you see always also the structural lesions, fatty lesions and erosions mostly. So either them alone or in combination with fat, this is the best performance of the MRI. So bone marrow edema is nice, it's very sensitive, but you increase your specificity and you increase, and that's the most important, the predictive value by combining chronic changes and chronic changes in bone marrow edema. These are preliminary data. We are now in the process of publication of this paper, where it will show also a little bit easier in order to digest. But please take into account bone marrow edema is not the only thing to look at on MRIs. Now, because of the time, I will not go into too many details. This is something that was published very recently. Just to remind you, it's not only the middle part. It's this is how the MRI looks like. It's the anterior, the middle, and the posterior part. Always look at those slices that are in the middle. This means here you have the cerebrospinal fluid. This you have the rectum, and this is more or less the cerebrospinal fluid that comes out. This means that's the areas I would not look at. The middle part of the spine, of the sacroiliac joint, is the most important one. And when you look for especially osteitis condengens, that's something that I have an interest in right now, because that's the most, let's say, important, the most frequent differential diagnosis for false positive MRIs. That's not so difficult to read. This is here those women that were having no babies so far, nulliparous. These are the ones that had babies in the last 12 months. And these are the ones that had babies, had delivery 24 months and beyond. And what was found was that if you look at bone marrow edema, this is the p-values. The nulliparous as compared to the early early postpartum were significantly different. This means the women that had just got the baby had more frequently and more severe bone marrow edema as the others. And as time went by, this means 24 months and later, this edema went off and it disappeared. So in the early phases after delivery, especially in the first 12 months, the edema and also the structural lesions may be more prominent, and then they disappear. And that was shown actually in another study, again, because of time reasons, I will not go into details. This is baseline, this is within 6 months, and this is within 12 months, or even shorter. And again, directly after delivery as compared to the first 6 months and as compared to the first 12 months, the more time goes by, the less edema you will find. You see here 60% had edema, then 15%, and this is just for patient I will leave it out because that's just a very short, very low number. Now, regarding the degenerative patients in the spine, just a comment on that. There might be, of course, also many different degenerative lesions also in patients with spondyloarthritis. So please check whether or not the back pain in a spondyloarthritis patient may not be due to spondyloarthritis but due to degenerative changes. Again, the numbers, I'm not pointing out the numbers because that's not important now, but it is a frequent finding to also have degeneration in the spine. Spondyloarthritis does not exclude degeneration. And for fibromyalgia, I think that's an important point as well. What we did was to check whether those patients who have fibromyalgia fulfill the classification criteria from ASAS. You see here they were diagnosed by the ACR criteria from 2010 and they were classified. These are diagnostic, these are classification criteria. They were classified also in most of the cases, but they were not fulfilling the ASAS classification criteria. Whereas on the other hand, the axSpA patients did fulfill the fibromyalgia criteria, and this was more or less independent of the stage of the disease. This means we may have secondary fibromyalgia, and that might also be positive in those who are MRI positive in non-radiographic stages, but the fibromyalgia patients are in fact MRI negative, and that's why they do not fulfill the classification criteria. That's why I would also be using MRI to exclude spondyloarthritis and maybe also clinically, of course, confirm fibromyalgia. That's the end of the presentation. One last maybe thing is that we have that's in German, I'm sorry about that. We have the recommendations for spondyloarthritis. We look for MRI lesions. We know that the MRI lesions really disappear, but they disappear slower than the clinical symptoms. This means we need 6 months to do so. And last thing, please do not monitor patients by MRI. If we check at baseline and we check at 2 years later under treatment, there is no correlation, especially for BASTA in MRI. There was a little bit of correlation by CRP and ASTAS. You see this is significant, but the correlation coefficient was low. So you can monitor patients, how they are doing under treatment by CRP or ASTAS. We do not need imaging for monitoring patients and treatment. Thank you. I think we were at the end, yeah. Okay.
Thank you very much, Xenophon. It was, as usual, excellent, and it was very practical, and I hope that it was very useful for young rheumatologists. Any question or comment?
Can I, please?
Yeah.
Yeah, okay.
It's Laura.
Okay, can you hear me, Xenophon?
Yes,
okay.
I can. Hi.
Very nice to hear you. It was an excellent talk, as Professor Kodan, you said. For me, it was even more invaluable because I have special thanks for the hint about the protocol for screening for spondyloarthritis with the special sequence in coronal fast tear. I didn't know about it. I don't know how I'll implement my clinical practice, but it's invaluable information. What I wanted to ask, because you tackled the problem that in clinical practice very often the radiologists, also the rheumatologists, are very focused on identifying the bone marrow edema. And for example, in my clinical practice, I'm seeing that radiologists sometimes do not mention the chronic lesions. For me, also, even if I have a special interest, I'm trying as a clinician to understand better, to look at the MRI images. I have problems in identifying some chronic lesions. How do you think that will be a strategy to implement this way of interpreting MRI? How to be more meaningful in clinical practice? For example, I've seen that there was an update of ASAS to define again some of the lesions, and there was a focus on chronic lesion, and they said that these chronic lesions are as frequent as bone marrow edema and also very reliable and easy to find, which we don't see in clinical practice. Also, for example, we have some problems in recognizing or understanding the so-called backfill. I never seen a radiologist here to describe this lesion. What can you suggest regarding this problem in clinical practice?
That is extremely important and interesting. You're absolutely right. Unfortunately, We are now starting educating radiologists, and I'm not meaning it, I don't say that in an offensive way. They just don't know about it because we are now learning about it more, like the study that I showed you or others. I don't say forget backfill, I'm just saying this is just one of the many different things. Backfill is just a fat metaplasia, by the way. It's nothing else. It's just located in the area of the joint. If I may, this is the part of the presentation I was not able to show you, but I will just show one or two slides. I will just share my screen again and come back to something that I think may be of importance to answer your question. And again, it will just take 1 or 2 minutes. Oh, sorry, hold on. So this is exactly your question. What about the chronic lesions and how do I look at them properly? You look at them, or the radiologist should look at them similar to the bone marrow edema around the joints. It is fat, it is erosions. And the way I just keep it, it's not important. The way we look at them is that we say periarticular location. For fatty lesions, we need homogeneous signal, and we need a distinct border to the remainder of the bone marrow. Okay, so it is similar as the bone marrow edema, but on the T1 sequence. That's nothing else. Backfill would be the same fat, but in the joint. Okay, and you may also have concomitant erosions. And one example that I brought in is this one. On the right side, the patient about 6 months before, a lot of edema, some sclerosis, fat. Well, this was not diagnosed at that time exactly because of what you said. I mean, not diagnosed means it was not mentioned, the structural lesions. But this MRI on the left side is also axSpA positive, even if the bone marrow edema has disappeared, but the fat is there. Okay, so this is of a similar, on the left side, of a similar value like the one on the right side. And you can, and you can make the same diagnosis. So what you look at is fat, with what I showed you before, distinct border, homogeneous signal, maybe with erosions, and periarticularly located, similar to the definitions we have for bone marrow edema. I would also transmit to the radiologist. I mean, that's the truth.
Thank you very much.
Thank you, Xenophon. Any other question? Yes, please.
Hello, Andra Mircea-Vicoveanu from Iași. I'd like to ask you, although the MRI findings are key in the diagnostic of ankylosing spondylitis, when this is not recommended, how useful do you think a CT would be in order to guide this diagnostic?
Well, I think that CT is okay, but you're missing obviously the inflammation. So it is, especially a low-dose CT, does not have much more, to be honest, much more radiation than an X-ray. But I don't see why to do a CT when you miss a lot of inflammatory lesions, which are also diagnostically important. If you do not have an MRI, or it's not easily accessible, or the patient does not want to go on in the closed machine, that a CT would be fine to check for sclerosis, to check for erosions, and so on. But MRI is much better.
I know, thank you.
Any other question or comment? It seems no. My final comment is a big thank you to you, Xenophon.
Thank you for the invitation.
It was a pleasure as always, and we'll see you again, unfortunately also online, on October 10th.
That's true.
Okay. Thank you very much and have a good day.
Thank you. Bye-bye.